you can let me know, should I go ahead and get started, or do you want me to wait for you to do an introduction, or you don't have to introduce me. It's okay.
Okay. I think everyone is aware of who you are because they went to the last one.
Yeah.
And we've been talking about you for a while. Um, so
I hope all good things. Good. Well, it's so wonderful to see you all again. I hope you all had a great holiday and Happy New Year and are keeping safe and healthy and in high spirits. Just by way of reminder, my name is Manpreet Singh. I am a child, adolescent, and adult psychiatrist at Stanford University, and I've been working on trying to solve the major problems or challenges that patients with who experience bipolar symptoms face, using a variety of different strategies. I do family studies in offspring of parents with bipolar disorder, follow them over time, look at their brain function, cognitive function, follow them for symptoms and how they evolve. I've recently been spending a lot of time with college students who are very close to their first episode of mania, and to try to get them on track to be able to be on the right kinds of medications. My hope and goal is to prevent bipolar disorder from ever being realized in some of these people who are clearly at very, very high risk, or to minimize the number of manic episodes that they have in their lifetime, knowing that the more mania you experience in your lifetime, the more complications that could potentially ensue. And so getting people on the right medication, getting them early treatment is a real big a sort of passion for me. And because I care so deeply about it being identified as early as possible, because I probably, just as you have seen the unfortunate consequences of delayed treatment and delayed diagnosis, I find it pretty curious that even among my colleagues, there's some skepticism that bipolar disorder could exist before the onset of adulthood. In other words, even though adults with bipolar disorder who've lived with the condition for most of their lives will describe early symptoms as early as childhood and adolescence, there's still a lot of doubt that bipolar disorder can't be diagnosed until later on in life. And so I've taken this debate, I guess you could say, on because of the consequences I've seen of delayed diagnosis and treatment. And I can share with you some observations I've had. Oh, it looks like, Katrine, that I cannot screen share, so I think you have to enable that if that's in any way possible. But I can just talk about it too. It's
let me do that.
And while we're waiting for her, does anything I've said sound or resonate with all of you? Can I see some maybe
Yes, definitely.
yeah.
I think a lot of us probably would have been much better off had things been caught much earlier.
Yes, I agree.
And I love
daughter would have
the
been
plan you have.
I agree. I was diagnosed just last year. I'm 46 years old now, and I believe I went through my first manic period when I was about 16 years old. Yeah. But I was diagnosed with MDD and anxiety, and well, here I am today. I finally got the right diagnosis and I'm on the right combo.
So, I asked a gal today, a patient that I just saw before I joined all of you, what it would mean to have this diagnosis. And, it's hard because at the time, if you're young, and for whoever's got their maybe themselves unmuted and some background noise, if you wouldn't mind just muting yourselves, that would be helpful. I was just going to say that, she said very interestingly, like, her mom has such disbelief that she could have this condition that it would really scare her to have acknowledged this diagnosis, and it would scare her to have to reveal it to her mom, who has such high doubts about it. So I also see, the other side of that argument, especially for college students who are maybe going through a lot of changes in their lives and they're not really ready to accept or embrace the idea that they might have something that requires more serious treatment. But in any case, and the other thing that I've heard from colleagues is that there's a lot of feeling like, it's kind of difficult for anyone to know, except in hindsight, that it was bipolar disorder all along and all those years that just wasn't diagnosed, when sometimes it's not clear because of the nature of the symptoms. But I will say that there are definitely some qualities, like the kind of depression people have when they have bipolar disorder is a little bit different than if you just had plain and bread and butter depression. And I'll just give you an example. The gal that I saw today described 3 suicide attempts. None of them actually worked, thankfully. She threw up pills that she overdosed on in 6th grade and in 8th grade, like 150 pills that she took in 8th grade, 60 in 6th grade, and threw them up immediately. Mom was in denial. She never got hospitalized. In 10th grade, she took a belt and tried to choke herself and was unconscious, but the belt broke and wasn't responsive for 2 or 3 minutes to her mom's knocking. She never told her mom that she was actually trying to kill herself. So her mom never knew until a therapist told her several weeks later. These are 3 very serious suicide attempts that went completely under the radar. They never got an evaluation by a physician. And in between 10th and 11th and 12th grade, things kind of continued to progress. And she finally began to have mania symptoms, more impulsivity, hypersexuality, more difficulties controlling her pressured speech in social situations, very impatient with other people. And those mania symptoms lasted 4 days, 5 days at most. So again, not a bona fide full manic episode, but very, very close, until someone recognized that maybe this is not bread and butter depression and treated her with the right medication. She had side effects, so she's had to go through a couple of different changes. But now it's very clear to me that had she not been treated with a medication that could help stabilize her moods, it was just a matter of time. She's 18 now, but it's just a matter of time before she would have had a full manic episode. So early identification and early intervention is critical. My interaction with her is, I don't want you to have full bipolar disorder. If we can help it, I hope we can prevent it. But one of the reasons why she's had such a rough time is because she took herself off of a medication, said, screw you. I don't believe that this is helping or working, so I'm just going to cold turkey. And that's been problematic. I think she's ready to finally engage in treatment, which I'm glad. The stars have aligned and we can work together. But hindsight, 2020, I don't know. She had depression, hypomania. And no one could say or fault the people who had thought she had depression all along, that she just had plain old depression until her mania symptoms hit, except that she had a bipolar family history. Her half-brother, who's 27, has bipolar disorder, and her father has married and remarried about 4 times and has not been able to maintain a stable relationship, marital relationship, and probably undiagnosed. So you know, I share this story because I see here and so many of these stories all the time in my practice, and I think that it's not right for us to simply say that there's a cutoff, an age cutoff by which you can make a diagnosis of bipolar disorder. I think you have to be curious. And I think anytime anybody presents with a depressive set of symptoms, you must follow that up with more questions and curiosity about mania symptoms, because if you don't ask about mania, you certainly won't find it. And maybe again, what do I know? I need feedback from patients, and it's very much what you have all said, or others have said who have educated me about this condition, to have me be curious when I see a patient with a child with depression, to scratch my head and wonder, is a kid who's adjusting to life stress or social stress going to be the one that tries 3 times, like in such a way? That doesn't sound like bread and butter depression or a psychosocial adjustment to life or puberty. That's not typical. And it merits further evaluation and also invitation by patients. Okay, let's see if I can screen share now. It looks like I can. And I guess I'll show you the slide presentation that I did at the International Society for Bipolar Disorders, because this was sort of a hot topic debate. And it's a hot topic debate because people are kind of the opinion that we want to be mindful and careful about overdiagnosing bipolar disorder. Here are my sources of research support and consulting. Children are not mini adults, but bipolar disorder, if we believe it's one overarching condition, has sometimes some developmental differences. So when it presents in earlier stages, it might look like ADHD. It might look like anxiety, or even OCD is what I've heard. A lot of goal-directed compulsive behavior that's actually probably hypomania, budding bipolar disorder. And so even though kids are not mini adults, the condition of bipolar disorder and our curiosity about when it can start should remain somewhat unbiased. Because if we shut ourselves down from believing that bipolar disorder can't exist until X age, what age would that be? What age do you think it should be? We can debate the prevalence. It's more common in certain ages. Yes, that's for sure. But can any of us answer the question at what is the earliest age bipolar disorder can exist? No, I don't think we can answer that question. Right? So the other thing to mention is that when you're not curious, a lot of things happen in the context of, okay, it's not bipolar disorder. I'm sure of it. It's not. It's got to be everything else. Kids go through this process a lot because the symptoms are kind of diffuse. And so what we call diagnostic orphans in psychiatry, when you don't have a diagnosis or don't have the right diagnosis, what usually happens? You go through what?
Go to a lot of different doctors trying to get different meds.
Exactly. It's exactly right. And it's also true that if you even look at people who have a genetic or family predisposition for mood problems, depression, bipolar disorder. Actually, what we've seen, and then what I'm going to show you in the next few slides, is that remarkably, there are some early signs in the brain that might actually be clues about the development of bipolar disorder or mood symptoms in general. But what it also says is that bipolar disorder is a brain-based condition. It confirms that, just like the genetics studies that we've done have confirmed that. So this is my former graduate student. Actually, I can now change this slide. This study has now just been published in Translational Psychiatry, which is open access, so it's free to look up. It's not behind a paywall or anything. And what she found remarkably here is that even before the onset of symptoms in healthy offspring, healthy, so no symptoms whatsoever, offspring of parents with bipolar disorder, you see different activation patterns in the thalamus and connectivities between the thalamus and other areas of the brain. So the thalamus is really important. It's an area of the brain that sits in the middle, and it kind of is the intersection on this highway between the areas that express emotion, the limbic regions, the amygdala, the reward centers of the brain, or the striatum, and then the front of the brain, which controls, it kind of acts as a mastermind or control system for all of those emotional expressions. When we see kids who express mania symptoms, oftentimes they don't have that impulse control. That regulation is usually because of delayed growth of the prefrontal cortex. What happens in mania or recurrent mania over time, the front of your brain that does that control center stuff shrinks. What does lithium do? It regrows, that shrinkage. So that prefrontal cortex, that mastermind, the control center at the top of your brain, is super important. And when you don't have that control center working properly, mania symptoms develop. When is the most likely period of time in development when that brain prefrontal cortex develops? It's in adolescence. So this is why we think that is a ripe time for mania symptoms to express themselves. So why prevalence of mania typically occurs onset-wise in adolescence is explained by this brain development, kind of how we understand how the brain develops, right? So that's sort of the kind of the general way of understanding it. And this thalamus, this really interesting region right in the middle of the brain that actually helps facilitate that control, is not working properly. It's not activating, and it's disconnected from other regions of the brain. And what's super interesting is that it's very specific to offspring of parents with bipolar disorder. And it's also different from offspring of parents with depression and offspring of parents who don't have a family history of any psychiatric conditions. So this is a case control study, and we've seen that this, even before any psychiatric symptoms manifest, there's clearly a difference in brain structure and function. Turns out that connectivity, disconnectivity, and that deactivation actually even predicts down the line. We followed these healthy kids up 4 to 5 years later, and the kids that were having difficulties making friends and keeping them, and the kids who started to express more depression symptoms and anxiety symptoms were the ones that had the most trouble. Is it going to then predict mania? We have yet to find out. But the thalamic function early, even before the onset of symptoms, seem to be playing an important role. This is a new discovery. We're very pleased to see some cohesion, because when we looked at this same issue and same structure in kids with bona fide mania, that same region came up while kids were processing rewards in the MRI scanner. The thalamus was deactivated and disconnected. And here's the follow-up slide that shows you that the kids who had this disconnectivity also showed difficulties with peer problems and higher rates of conversion to some form of a mood problem, whether it's depression or anxiety, which we know if you start from a stage of health, depression is going to be probably the most likely first episode. And anxiety and OCD and all of the things that kind of prop up, in my view, as prodromes to an eventual mania. Some of the doubters have also said, look, this is a case of American exceptionalism. Everybody is, making such a fuss, but it's the Americans that are making a fuss. Well, all you need is a pandemic to remind us, we are exceptional in America. But in my view, we're exceptional in America because we are a melting pot. We have people from all over the world here. That's not true for any other area of the world. We have more diversity here than we ever have. And so if we are a microcosm of the global community, then yes, we're exceptional. But it's very clear from our European colleagues, Australian colleagues, Indian colleagues, Asian colleagues, and elsewhere in Asia that bipolar disorder isn't just an American phenomenon. It happens everywhere. This is the picture of the brain that I wanted to show just to remind us that, there's lots of different things that are affecting our brain as it's growing. In fact, we're even doing a really, really great job preventing mania from actually occurring because it's so disruptive. And when we're young, our young brains actually have do a really good job of it. So there's an innate adaptive processes. Probably why not everyone who has a bipolar parent goes on to develop bipolar disorder. In fact, many offspring are resilient. So we're very interested in what those mechanisms are too. And it's so complicated that it's not like one gene or one mechanism or one theory that works here, right? It's all these factors that kind of are coming into creating a kind of a series of gene by environment conditions to lead to the first episode. And what we also know is that with episode development comes a fair amount of emotion dysregulation, cognitive impairment, and of course, interpersonal challenges, family conflict, friendship conflict, impatience, difficulty, understanding. I wish we could have interviewed my patient from today. She described beautifully the impact that these kinds of symptoms have had on her relationships with her friends. If it doesn't occur, why doesn't it occur? Well, the other thing is that there's individual differences, and that's true of mania. Like there's no one single flavor of it. There's lots of different variabilities. And we might be intervening, like the gal I saw today who got Vraylar, then Lorazepam and Prozac and all sorts of other things. Prozac was always given with a mood stabilizer, which is great, but she has migraine headaches, so she could have gotten amitriptyline, which may have also contributed to subthreshold mania symptoms. We don't know if it's medication that's causing these things, but if you are going to have it and medication taking it away didn't make the mania go away, it was probably another, factor that contributed. So again, the conditions, the perfect storm, I suppose you could say, that creates a manic episode. And I think what we need to do is in some ways use some Bayesian, what we call in fancy statistics, to think about the probability. And so often we talk about the probability of having bipolar disorder being pretty low because it's an uncommon condition. It's a 1% global prevalence. But for me, it's not just important for us to doubt it. It is also important to be curious about it. Be skeptical, but be thorough. And don't let your biases prevent you from actually assessing for it. So what are the harms of missing it versus calling something manic that it isn't? What's the challenge with false positives? Well, you might get a misdiagnosis in the wrong direction, right? If you overcall bipolar disorder early on, kids can be exposed to a bunch of inappropriate treatments, mood stabilizers. There's a whole host of stigmatizing aspects to having a bipolar diagnosis. If you don't have it, then you shouldn't be walking around saying that you have it when you don't. And so that's an important argument. But from my perspective, there's also challenges with false negatives, because if you don't look for it, or if you just dismiss it, it can occur in childhood, pre-pubertally, or any time before any, expected time frame. By the way, kids are hitting puberty much earlier than ever before. So what are the challenges with false negatives? Delays in diagnosis, multiple failed and sometimes inappropriate treatments. Sometimes you get induction of mania from antidepressants. You can't get to the right treatment, and there's no resolution of the ambiguities because we tend to believe that it doesn't exist. So clinical observations, sociodemographic, biases, like, oh, this person is white male. How can white males have it? Just an example. It's just not true. Bipolar disorder is cross-cultural and presents everywhere. So why would anyone have any pre-hoc assumptions that race or gender should have any bias? It presents differently in different people. We should have some understanding of how that could be. And as a result, it might be treated differently in different people. And so why wouldn't that be? So it's important for us to be cautious about how we're oriented, whether it's misdiagnosing it or missing it. And what we do know is that for those kids who have prepubertal onset, they need to be followed carefully, because many of them who have presented in early childhood do go on to have mania in adolescence and in young adulthood. There is a continuity. It may not be very common, but it is there. So because we've seen evidence of that, then we shouldn't just write it off. Here's the business about antidepressants. We know from many, many case reports that antidepressants can escalate to a mania. So if you're treating a unipolar depression without having ruled out mania first, you might predispose them. Kids who have a bipolar family history and have had an antidepressant have smaller amygdala volumes when they've had bad reactions to them, and their amygdalas are hyperactive. So we think that this, and others too, have noticed this observation. So we're doing a clinical trial now to see where is it safe to give an antidepressant, particularly if you have a family history of bipolar disorder. So the things we have to pay attention to in non-high-risk samples is that mania can occur and seem to occur more generally in adolescence, for sure. Denying the existence of bipolar disorder in kids is poor medical practice. It's poor science, and it risks us setting the field back. Transdiagnostic or other formulations of pediatric bipolar disorder, like let's just blame the parents, or let's blame the kid, it's just a disruptive tantrumy kid, those are perilous in their own right and are stigmatizing. And we must follow kids over time. It will tell us definitively, but it may not tell us everything. And so if we walk in with an open mind and assume that there's lots of different possible trajectories, that no one is ever doomed to have bipolar disorder, but that there might be some early predictors of long-term or chronic bipolar disorder, we need to understand what those factors are, because a chronic diagnosis of bipolar disorder must be intervened early and must be optimized to improve the trajectory and prognosis. And bipolar disorder is by nature a variable condition, and we should look for clues for understanding that variability. And really, kids are the optimal sources to understand the roots of this disorder. So we really need to do some more work to understand early biomarkers for detection. We need to implement preemptive strategies like family-focused therapy and other non-invasive strategies to potentially prevent progression towards bipolar disorder. And for those living with bipolar disorder, we need better treatments. How can we do that if we don't understand the pathophysiology of the condition? Very, very important. And I'll use my colleagues from Alcoholics Anonymous to provide a nice ethical roadmap for evidence generation. We must grant me the courage, God, to use random allocation when needed and the serenity to accept causal inference with best possible methods when randomization is not ethical or feasible, and the wisdom to know the difference. We have work to do to learn more and do it in an ethical way. So when you see this drop in the number of scientific articles being conducted or studies being conducted and reported out in the scientific literature drop in the field of bipolar disorder, and particularly in kids, that should be a warning sign. We cannot stop our search for understanding of this phenomenon because we have doubts about its existence. We must change this so that we can better understand it, because for all the healthcare dollars out there, it seems like even though mental health is the leading cause of years lived with disability, the level of funding for research on this condition are unfortunately not well matched to the amount of disability caused by it. And look at the number of years of life lost. Certainly we're not at a place where it's as much as it is the case for cardiovascular disease and other things. But you can imagine that many of those other things that fall above mental health are often exacerbated and worsened because of mental health issues. So we have some work to do to partner together. I want to acknowledge you all because, again, without your input and information and guidance, we wouldn't have a rational approach to understanding bipolar disorder and its consequences. It's very important and vital for everyone to partner together to understand this condition better and to help develop better treatments. And I'm very pleased to share with you that our Mood Disorders Center was recently awarded a Community Merit Award from the National Alliance of Mentally Ill because of the annual education day that we do to try to make sure that the community and patients who contribute to this research have an opportunity to hear about the findings and new scientific findings directly from the scientists. Every year we do a Mood Disorders Education Day, and we've been doing it now as a virtual platform. So I will extend the information to Katrine so you guys can learn about it too, and you're more than welcome to join and register for that annual update as you wish. I hope you'll join us for that. Usually it happens in August of every year. And besides myself, there's a number of other folks who are interested in this effort and care deeply about making continued connections with the community to advance the field. So that's what I have to say about the bipolar controversy and what my general thoughts are. I'd love your input in the remaining time that we have, and open to dialogue as always. Thank you for listening.
Thank you.
Katrine, was that helpful?
Yes, thank you so much. Does anyone have any questions or comments?
I just
Some
wanted
of
to say that it really helped me out a lot because my son, I see a lot of bipolar symptoms in him, but nobody will diagnose him because he's so young. He does come from a long family history of bipolar disorder, so that was helpful to me.
Great. Yeah, I mean, what I like to do when I see patients early on too, when it's not clear what's going to happen, is always look at the glass as half full. And I'm not a person that tends to look at it as half empty anyway, but people want me to look in a crystal ball sometimes and say, can you, Dr. Singh, tell me 10 years down the line, is my kid going to have bipolar disorder? I can't do that. But what I can do is give you the education and arm you with the knowledge that you need so that you can look for the clues and get your child help earlier than later, so that if there's any whiff of anything, it can be evaluated early and treated early. And that's right now the best we can do in the absence of any blood tests or biomarkers. But eventually we'll get to a place where we can even use some of those things. And even the imaging stuff is interesting because it allows us to look for early clues. And it at least informs us to maybe pay attention to regions of the brain that might actually be very important to understanding how this condition works or develops. In the long run, in order to make headway on better treatments, we absolutely need to do that work, right? So that work must continue. And our curiosity for this condition must continue so that we don't miss an opportunity to discover an even better treatment.
I just had a comment that I want to thank you for being willing to try to tease apart the different pieces that this one is more likely to lead to it. Because I think a lot of times doctors just don't spend enough time thinking about that sort of thing. And unfortunately, it leads to people not being diagnosed when they should be. Your story of your recent patient really hit home with me because I was in a very, very similar situation when I was in my teens.
Mm-hmm.
And I was not diagnosed until 26 because my mother didn't believe in mental illness. When I was finally diagnosed, her answer was, "You didn't get that from me." So yeah, you are really doing such important work and you're getting people's lives back. Because if you lose time in that precious development time, it is so harmful.
Yeah. Thank you for sharing that and for explaining and highlighting the value of early detection. What do we do about those moms? And, I mean, part of it is the stigma, right? I mean, nobody wants to have this thing going on. You're to blame, or because it's so emotionally charged, and that's not the goal. When I was trying to frame the family history piece to this patient today, I was like, there's no blame here. Family history is part of our understanding that these things sometimes run in families. So understanding that clue helps. It helps understand the diagnosis more. And frankly, sometimes when traits run in families, it is explanatory. It does help. Whether you get that from me or dad or whatever is besides the point. It's the fact that there's clearly something there that's biological, that's brain-based, that's not, no one can stigmatize and say it's your fault. It's meant to take the spotlight away from you. Right? I mean, that's huge in my mind.
Yeah. The bottom line too is the kid needs help. Your child needs help.
Yeah. And it doesn't matter, right? I mean, uh, so maybe it's an academic thing than anything else. So I try not to spend too much time focusing on it as a sort of an understanding of how these symptoms manifested, because it can cause kind of conflict among family members. But I will tell you, the denial also runs deep. Just as the phenotype does, just as the characteristics of mania, right? And so, how do we understand denial? Well, some of it is, part of the disorder. Let's acknowledge that, there's aspects of bipolar disorder, especially mania, when it feels good and you're on your game and you do really well and, things kind of, nothing can go wrong. Denial is really helpful in that context. Nothing's wrong with me. I got this, right? Um, and for some, actually, there's no reason why we shouldn't celebrate the beauty that comes with mania. There's actually beauty in mania too. As much as it can harm, there are aspects of it that are absolutely beautiful. Creativity, what comes from a manic episode can be amazing. The challenge is the other side of it. And so getting to a sweet spot is where I try to explain to patients that the goal is to live your best life. And you're right, it has to happen as soon as possible, because if you can get to a place of getting to your best life without all the other stuff, the negative consequences, there's also, in my view, that's beautiful too.
I think some of the stigma from bipolar disorder comes from, it used to be that doctors blamed the mom. And so that's part of it, I'm sure. And then there is guilt. I mean, I have two children with bipolar disorder who are adopted. I still have guilt, even though I know that, I know it was genetic, and it's still a lot of guilt for parents, and it's hard for them to deal with a lot of times. And that's part of the denial.
But Carrie, can I ask, if we understand it to be a brain-based thing, right? Like, okay, you can layer in the genetic piece, but which, by the way, again, is so complicated. Like, the variance of it is so tiny that, like, it's so complex, not a single gene, really, really hard to tease out. If we shift the focus on the brain and wiring of the brain, I've always assumed that was a good way of destigmatizing bipolar disorder, like, so blame the brain. But for whatever reason, we kind of give our brain, even though it's an organ, a physical organ. I could show you, I have like squeeze balls, stress balls somewhere in my office here, with brain squeeze balls. But, you can look at the anatomy of brain. It's a physical thing, but we personalize it because of this real interesting connection between the brain and the mind, right? And then the stigma sticks. But I'm curious if you guys think there's another way to really formulate destigmatizing. Because, like, in the past, people have used sort of chemical imbalances, and we know it's much more complicated than that. What do you think? How does one destigmatize this clearly biological condition?
I think it's one of the biggest fights we have. One of the biggest fights we have is the stigmatism. I mean, both me and my brother are diagnosed bipolar. My mother was the first, just like Chris. I don't know where you got it from. My daughter was diagnosed very early, well, at 14. And so there's like this clear chain, but it's still stigma still there. Yeah. My daughter was actually diagnosed before I was, but I think that's our biggest challenge is the stigmatism.
I do think doing what you're doing and pointing out that it is, a function of the brain, is the best way at this point, other than people being willing, like Katrin, to, step up and say, this is part of my life and I'm okay with it. And I think that's part of it too, is that we need people who are willing to do that and say, yes, that this affects me and I have to live with it, but it doesn't define me.
Right.
So I think that's very helpful, especially in our social media kind of culture.
Well, COVID.
It's really hard though for people in business who have to make a living and survive to be out.
Yeah, I agree.
And I'm fortunate I can be out. But I can also see other people where it's going to affect their ability to work with clients or get promotions or any of that, even keep their jobs at times. And it's not possible. It's simply, right now, it's not possible. And when you characterize it as an illness, I think that helps as a physical illness, as your brain has an illness. Maybe that helps. I don't know.
Yeah, high blood pressure doesn't get the kind of play.
No.
It's, in my view, this, a very similar concept, but yet.
Well, it doesn't make people behave strangely. And I think that's really a lot of what we're looking at, is it makes people behave in ways that other people don't understand.
Yeah.
Yeah, I was basically forced to retire because of my bipolar, because it was stigmatized that they ended up having me retire. But education, I think, is one of the biggest things, like Carrie was saying, is to educate everybody as much as you can.
Mm-hmm.
I used to think that education was the way to end the stigma, but you can't educate the unwilling. There has to be a desire to learn, or you might as well just teach them all.
You're absolutely right, Shauna.
Mm-hmm. Yeah, I think even our general practitioners probably need to be better educated. The ones who are coming in contact with people who have young kids who are, my daughter, she was showing signs of depression at 4. I took her in for counseling because she was drawing pictures that were all in black and things that were not happy things. And so she got counseling at the age of 4. And so I think even just, educating our general practitioners that, when kids are displaying, depression, when they're this young, this is what we need to be looking for and other signs of it for the future. And I think that's part of it too.
Yeah.
I remember as far back as I can, just the depression side of it, as far back as I can remember.
Wow.
Mm. Which in and of itself is a clue.
Mm-hmm.
Right? Super helpful to me to hear your thoughts and reflections. We have work to do to bridge, to build bridges with folks who might be in different states of mind or skeptical. But I don't see how we can make progress if we don't attempt to build. So, I think that the patient voice is so important in this. We can, as academics, we can debate all we want, but at the end of it, what really matters is those living with the condition or have family members with the condition and are also living with it. In order to be able to make progress, we have to be able to learn together. So I really value the opportunity to have an open dialogue with you all and to keep that communication flowing. but also to be able to say if we can give back, whether it's through education or innovation, and also continued clinical efforts. All of that matters for our progress. And I tell these, these patients that I see who are really clearly in that very, very important zone, that time frame that's most likely for onset. It's just such a critical window to establish trust with a healthcare provider. And boy, do we screw it up. You know what I mean?
Oh, yeah.
I can have humility about that. Not a lot of people can.
Yeah, that's because you're not one of the ones really screwing it up.
Yeah. I was diagnosed with depression before I was ever diagnosed with bipolar.
Yeah. All right. Well, I've got to go and herd cats. I don't know about you all.
Thank you so much.
Pleasure.
Thank you so much.
Thank you.
To see you all again. I hope you
Thank
guys
you.
all stay well and enjoy each other and continue to support each other. This is a really important time for us to continue to rally. It can get lonely. So try to, really work out and reach out to each other. That's something we're all feeling. And if the pandemic can teach anything about destigmatizing our needs as humans that are so fundamental, I don't know what else will help us. God help us. All right. Take good care, everyone.
Thank you.
Thank you. You too.
Bye bye.
Wonderful to talk to you. Bye.
Bye, guys.
Bye.